Thank you, everybody, for coming today. It's my pleasure to be here representing Dr. Jones, Peter Jones, who unfortunately was unable to make it, but he sends his best wishes and his regrets. I was told to put the disclosure slides up, but not to speak about them, so I won't. And so, broadly speaking, so the title of the slide of the presentation is just a little bit misleading. We are going to speak about the health economic impact of increased dietary fiber intake, but more broadly, the presentation is about the research program that we have at the Richardson Center for Functional Foods and Nutraceuticals with respect to nutrition economics. So I'll try to go through the slides quickly until we get to the point that does relate to the topic of the presentation, but I think it'll be instructive to provide you with an overview of the general research methodology, which we've now implemented a number of times. So, of course, healthcare expenditures being a very considerable proportion of the public purse here in Canada. So many of you will be visiting from abroad or from the US or other places where healthcare is financed in a different way. So very broadly speaking, I would say that our interest in the research is to acknowledge that public healthcare expenditures are extremely high, as we'll see in the ensuing slides, and that it is in everyone's interest to look for constructive ways to reduce these expenditures. We're now talking about more than 50% of public budgets. So healthcare expenditures are quite a significant concern for every taxpayer, as well as, of course, every individual from their personal health standpoint. We see the incidence of diabetes is very high in Canada and worldwide. We see that cardiovascular disease, which has been the focus of a good deal of our research, is a very costly disease as well. So worldwide, looking at more than $1 trillion predicted by 2030. I don't want to spend too much time here, but Canada actually doing a little better than some countries in terms of percentage of GDP spent on healthcare. However, it is entirely public funded, which is not the model worldwide. Showing that even though what we would call nominal healthcare costs in the darker shaded boxes have gone up considerably, even in real terms. So in constant 1997 dollars, we see that increasing costs. So it's not just that services are becoming more expensive, they're also increasing over time. And that is really the threatening part of the entire equation, is with an aging population and a percentage of the population in certain demographic groups that are very large consumers of health care. It's a troubling pattern, and one that is worthy of being addressed, which is what we're hoping to do in our research. So just a few more statistics on starting with diabetes, looking at Canada of associated healthcare expenditures of $17 billion by 2020, which is a big number, of course. We see cardiovascular disease, CVD, being an important consumer of healthcare budgets as well. And it is an ongoing issue. So switching now to the approach, the potential approach to it. So of course, nutrition, eating patterns are a very important way to deal with these things. We know people don't eat well all the time. Many people do, probably most of the people in this room do, but it is a huge public health issue. Nutrition is one of the most obvious and most effective ways to address poor health. One of my research interests is estimating how people assess and discount their future health states. So people do things that are bad for them every single day. The problem is your health gets very incrementally worse. You could take somebody whose eating pattern today. In fact, I'm involved in a little bit of nutrigenomic research at the University of Manitoba, where we're trying to get more reliable predictors of future health states. Even so, people look at a future health state. They could even look at their family history and say, wow, I've got all this diabetes, or I've got all this heart disease in my family. And I know that this could be a problem for me when I'm 60 like it was for my dad or my mom or my grandma or my grandpa or my uncles or aunts, and I'm still going to pop open that bag of chips or that bottle of Coke because that's so far away when I'm 35 or in my case 42. So that's one of the things I'd like to explore more as to how people make those decisions, how they discount those future health states. So it's an interesting avenue, one that we haven't explored too greatly yet, but that lies down the road. So some more statistics that you see, just again underscoring the point that this is a major area. Nutrition economics, I'm not entirely comfortable with the development by nutritionists, I have to say, of a new stream in my field, but it does fit the bill. It's a little bit different than health economics, and it does, I honestly believe, contain a great deal of potential for the future in terms of cost savings. So again, just a little bit of a broad overview of some of the stuff that, and the way that we're thinking at the Richardson Center for Functional Foods and Nutraceuticals at the University of Manitoba. Just a little bit of a description of how we have the marriage of these two fields of study. There was a different quote in here, but I decided to cite myself. This definition could be found only in my head. So I had personal communication with myself this morning as I went through this slide deck and came up with this definition. Explores the relationships between food, nutrition, disease, healthcare states, and the financial dimensions thereof. So that's me. I like it better than what was on the slide before. So a little bit more about the thinking behind what we call nutrition economics. I think fits fairly well with what I've just introduced to you. How do we measure these benefits? So we actually had a paper in, I'll just give you the citation there. This was in Nutrition Reviews back in 2012, principally written by the lead author there, Colin Giles, myself, and Peter Jones. And so here we go back just for a second to the methodologies, which some of you will be familiar with. I don't want to spend too much time on them, but the paper that I cite there has a pretty incisive, definitive overview of the work in the field. And so the paper's been cited a number of times. It looks at the different authors who have undertaken cost-benefit analyses, cost-effective analyses. Our chosen method to approach this line of research has been cost of illness analyses. There are other boutique approaches that make sense. They're often usually done by economists, and so haven't been that well known in the nutrition literature, although there have been forays into that literature as well. So our method has been COI at the bottom, cost of illness analysis, that measures the direct and indirect costs of a specific disease. So again, the slide there shows the citation, which can be found at your leisure if you're interested. Just picking a couple of the papers that we cite. There were several dozen that we looked at, identified, and explored and categorized, taxonomized, I guess, in the paper in Nutrition Reviews. There's just a couple, one by Dahl et al. From 2009, and had another one there, but I lost it. Our first foray into this cost of illness type approach was back in about 2008, so this paper published in 2010, as I recall. And so it was economic valuation of the potential health benefits from foods enriched with plant sterols in Canada. At that time, plant sterols were licensed for production, consumption, introduction into food products in almost every other country in the world, certainly all other well-developed countries, but not Canada. And so there was a group called Council for the Adaptation of Plant Sterols in Canada, something like that, CAPSIC, that some of you would be familiar with, that funded some research for us to try to demonstrate that there would be economic healthcare savings associated with introduction of plant sterols. Of course, subsequently they were allowed to be introduced into food products. But this was the first attempt that we made. Again, Colin Giles, a current PhD student of mine, being doing most of the work there with Peter Jones, providing the conceptual oversight of that project and most of the ones that we have done subsequently. So as I said, we just wanted to look at what could be done or what there might be in terms of cost savings. So the general approach is we've used for most of these, We've sort of refined it from a 4-step approach to a 3-step approach. Basically, we choose a success rate. So based upon the literature, we say, okay, if plant sterols could be introduced, for example, at the time when we did this work, as I said, they weren't. If they could be, how many people would realistically begin to consume products that contain them at the rate necessary to affect a positive change in cholesterol levels, for example. So you choose a success rate based upon the literature. And I think we ended up with going with Norway or Denmark's rate. I can't remember for sure. I think Norway. So introduce plant sterols into the diet. What associated reduction would there be in cholesterol? As a result, what reduction would there be as a result of reduced cholesterol in coronary heart disease in this case? And then finally, the 4th step is to try to calculate an economic healthcare cost savings as a result of the reduced disease state. So we've used this approach or a modification of this approach broadly in subsequent work, and we are looking for ways to refine the approach to make it a little bit more statistically precise from say, an econometric standpoint, but that is the general approach. At that time, and what we've done subsequently is to say, here's the very best case or ideal scenario, and here's a very worst case or very pessimistic scenario. So I don't want to spend too much time on this paper. The next set of several slides are just relating what we've done and what we found. And so just to show that all of our assumptions were based upon a careful review of the literature. And when we had to make some sort of a leap because we didn't have a good reference to rely upon, we explained it carefully. So the original paper published in Nutrition Reviews back in about 2010. As I said, I think the work commenced in about 2007 or 8. So again, just going through the set of steps. So you eat some level of plant sterols, should be associated with some reduction in blood cholesterol levels, should lead to a reduction in coronary heart disease, and there will be some healthcare savings associated with that reduction in coronary heart disease. So these numbers are from the Economic Burden of Illness report. When we did this first work, the best numbers available were from 1998. They've since been updated, so subsequent work has relied upon newer numbers. And what we did was just use the Statistics Canada Consumer Price Index healthcare subcategory to update the numbers to from 1998 numbers to 2000 numbers, so that we had something that made sense in 2007 dollars. So you see, I'll speak later on about different types of direct and indirect costs. So we in the paper that I'll focus on a little bit later, that relates to dietary fiber, we sort of have mortality and morbidity as the main categories of indirect costs. So there are reductions in some types of costs when, say, coronary heart disease or cardiovascular disease is reduced, but not others. Fixed costs, we said, don't really decrease because you still have hospitals open, et cetera. You still have doctors working there. But other types of costs could be reduced. So you can look at that paper at your leisure if you're interested in more information on the specific approach. Also, the paper that I'm going to talk about with respect to dietary fiber is in review right now, but if you email me, then I will send it to you. And you note I have strategically failed to provide you with an email address. But it is jared.carlberg@umanitoba.ca for anybody interested in reading the dietary fiber paper in review right now. So we look at proportionately, said, really it's only the variable costs that we can affect by these reductions in the short term. So what we're trying to do is take pains not to overstate the reductions that could occur. Nobody would value that, and I don't think as scientists we could stand behind it, but I think the numbers that we've come up with in our various works have been reasonable. So again, just looking at the numbers behind the scenario. So remember, step one to specify a success rate. So all we see there is that in the ideal scenario, 47% of people would consume plant sterols in this case at a level that would affect a positive reduction in blood cholesterol levels. So we have 4 scenarios, And you see the very pessimistic scenario is indeed pretty bleak and probably unrealistic. So somewhere in between the optimistic and pessimistic scenario, we believe, would be reality, and that is in the $257.5 to $630.4 million annually healthcare cost reduction range. So what I'm looking for and hoping for is some feedback and improvement, potential for improvement on the economic methodology. So as I admitted before, I understand not that much about nutrition. I think that I understand that if I eat more fiber, that's good, and less fat, that would be good, and less sugar, that would be very good. But other than that, looking for good feedback on the economic stuff. And so my colleague Peter has I actually removed it from the slide deck on several slides. He had what he referred to as a theoretical probability curve. And I think I teach undergraduate econometrics, actually, so my knowledge of statistics is slightly beyond rudimentary, but not much. But I think what he's referring to is a cumulative distribution function, really, which is to say we come up with 4 scenarios, but there are literally an infinite number of scenarios. As you all know, the real number line is infinitely divisible. And so somewhere in here we can do better with respect to modeling probabilistic outcomes or attaching probabilities to levels of healthcare savings, which I think is one of the major improvements that could be undertaken to the economic component of this work. So the theoretical probability curve is no longer overlaid over this stuff. I was kind of half expecting it when I pushed the next slide button to pop back up and make a liar out of me, but it didn't. The second substantial work that was undertaken at the Richardson Center for Functional Foods and Nutraceuticals, as you see RCFFN there, was Mediterranean diet valuation. I wasn't involved in this research, but it worked in largely the same way. So basically looking at what kind of cardiovascular disease reduction could we expect as a result of more people following the Mediterranean diet, and what would be the economic cost savings in a healthcare perspective if that occurred. And so this is in press, accepted at Food and Nutrition Research. I believe that's the same journal where our original work on phytosterols was published. So I think that should be available. If you're interested in it, I can certainly get it for you. Sort of compacting our 4-step approach down into 3. So a success rate leading to cardiovascular disease reduction. Again, numbers based upon reviews of largely meta-analyses that have taken place and been published elsewhere. So not numbers that were just sort of made up by the researchers, at least not to my knowledge. So looking again at a 4-scenario, ideal, optimistic, pessimistic, and very pessimistic or bleak set of outcomes, we said if between 5 and 50%, or they said if between 5 and 50% of the North American populace followed this med diet, you would see the healthcare savings, ideally, that are represented there. So our most recent work has focused on dietary fiber. And so that's the work that I'm wanting to talk the most about today. I know the least about it. So peter.jones@umanitoba.ca if you have questions. But focusing on constipation and type 2 diabetes and CVD. The little girl in the slide looks a lot like my daughter. However, she is probably in our house having a dispute with her mother at this time, as opposed to being constipated when that expression comes up. And I'm sure many of you are in the same boat. I have 4, so my one-day stay in Toronto was difficult for my wife, but kind of relaxing for me, despite the spotlight and the threat of having to kiss Vladimir. So same approach that we've taken before, a success rate to get people up to the level of dietary fiber intake recommended by the IOM, as we'll see in the next few slides, leading hopefully to a disease reduction and reduced healthcare costs. Constipation, not looking to focus on too much because I'm probably running a little bit short on time, and I think the focus that we're more interested in here is upon diabetes. I note that the conference actually has diabetes in the title and therefore feel compelled to perhaps get to it. This is under review. As I mentioned before, the paper is available for you to look at if you'd like to. I hope I don't get in trouble for saying that. Peter will slap me on the wrist when I get back, maybe. But getting then to some of the numbers that are interesting, focusing on dietary fiber and type 2 diabetes, cardiovascular disease. So been associated with lower prevalence of these food-related chronic diseases. A little bit about where some of the numbers come from. Again, the paper would have more detail on those if you're interested. Getting kind of to the heart of the matter here. So looking at current fiber intake, which is significantly below what are recommended by the IOM, as we see there for men and women of 38 and 25 grams per day respectively. We go through some numbers of incrementally reaching that recommended level of intake. Again, we're looking at doing this using cereal fiber. And so we see then the type 2 diabetes reduction per 1 gram cereal fiber intake in percentage, so a 2.5% reduction for each and a 1.1% reduction for each. You see the references there. So the set of assumptions, if these levels were achieved, we see that we would have non-trivial healthcare cost savings of 35.9 to almost 800 million in type 2 diabetes costs, and 65 to about $1.3 trillion annually reduced in cardiovascular diseases. So the same approach that we've used in the past that I've tried to describe for you today. A set of assumptions. We look at scenario analyses which are try to take into account anywhere from ideal scenarios to very pessimistic scenarios, and then present for our readers the opportunity to decide what they think is reasonable. And so each 1 gram per day increase in cereal fiber has a pretty significant healthcare cost savings associated with it. So we see for diabetes and type 2 diabetes, and cardiovascular disease, the numbers up there. Again, more detail in the paper that goes through the assumptions more carefully, would cite the references for you where the assumptions come from. Looking at, again, just under the 4 scenarios, and so Dr. Jones in the previous version of this had overlaid, again, the what he termed the theoretical probability curve. Again, just trying to note what outcome is more likely. So it doesn't do us a whole bunch of good. This gives us a pretty good idea of what might happen financially, but it would be nice to see it associated with probabilities. Obviously, the optimistic scenario and the pessimistic scenario have a higher probability of occurring than the very pessimistic or the universal/ideal scenario. So trying to attach probabilities to it would be a statistical improvement, I think, of our work. We see the same information. So type 2 diabetes, and then apparently, just for variety, we changed the format of the chart to get cardiovascular disease. And so, again, just to tie everything together, scientists provide health-based evidence, scientists like yourselves who are mostly nutritionists, doctors, etc., real doctors as opposed to doctors like me. And so consumers are therefore responsible for taking into account their health states. I think I've somewhat callously at times said, so my wife and I and many of the people here pay a lot of taxes, and more than, so forget about income taxes, add to that sales taxes and all forms of taxes. We pay a lot of taxes, and more than half of those tax dollars go to support health care. So I think it's sad that people, watching my father die after having a stroke, a lifelong smoker, poor eater in some cases, did have diabetes in 2008 at the age of 73, I guess he was. Kind of drove the point home, right, of watching someone kind of lay in the hospital for a couple of weeks and then kick the bucket. So those healthcare states are hard to see. Families suffer, people suffer, businesses suffer because they deal with morbidity, they deal with turnover costs. It's quite gross. But as a taxpayer, forget about all the other stuff. So if I'm a cyborg just paying taxes, which is how it feels some days, that's what I'm interested in. So maybe my family paid $40,000 in taxes last year, and $25,000 or $22,000 of it was healthcare costs. It'd be kind of nice if that was like $38,000 and $20,000 of it were healthcare costs. So those are the interesting parts from an economist standpoint. But the personal health outcomes are interesting from everybody's standpoint, I think, because even though we do discount those future health states, they are coming. And I think that I'm not much of an interventionalist when it comes to regulatory affairs. Now, many of you are in the field of healthcare and nutrition, and so it is necessary. There was a good reason, probably, why the Canadian government took longer than everybody else in the world to license plant sterols, but they're careful. Food is important. I'm not much of an interventionalist, but I think that it's a call to order for governments to look from a regulatory standpoint at more carefully regulating. Small items are things like nutrition labeling requirements. So Center for the Study of Science and the Public Interest, CSPI, that some of you will know here in Canada, has been on the warpath with respect to sodium for some time. So that's good. Public education campaigns that focus on doctors, because they're the ones seeing people on a day-to-day basis, are good. Outright bans. I'm not much of an interventionalist, but if we can make people healthier and if we can save lives and if we can, most importantly, reduce my tax bill, then I'm in favor of it. And so I think that the unique structure of how healthcare is funded here in Canada and the unique structure that we have, especially in pockets with respect to certain demographic groups, it could be a winner. And so our line of research has merely been to try to start to have the conversation about there are real savings to be out there and to be realized, and let's start that. And so I'll get to I'm getting the evil eye here from my chairs, both, and we are now done. And so I think I've kind of covered off my what I wanted to say in the summary slides. So we could do a little better. We could reduce my tax bill and yours. We could save some lives. Our research is merely just to try to point that out. I'm very keen to receive any suggestions you have for improvements in the methodology from an economic standpoint. I'm sure Dr. Jones is as keen to receive your suggestions on any criticisms or observations you might have about the nutrition side of things. So again, any questions or requests for any of the papers that I've cited today, jared.carlberg@umanitoba.ca, and the spelling of my name can be found in the program.
In the days before we realised the true potential of decrease in health, decrease in disease from consuming dietary fibre, the UK made an estimation of the costs of adding dietary fibre to the diet. And the overwhelming cost which they thought, and I hate to say this because I don't want to spoil the approach to increasing dietary fibre intake, but you may well have evidence. The amount of money spent on sewage works had to go up, and that was a bit of an inhibition. What other sorts of costs are there which would make the sponge be one where the savings will not be those that predicted by the healthcare costs?
So that's a very good question, and I think that as we try to refine and make our approach more sophisticated, we would have to look at that. That's a good example of infrastructure costs. We think that for some types of it, we're not advocating that there would be a public expenditure to help with increased fiber intake, but there are related costs that you identify. We also think it's possible that we haven't captured all of the private sector cost savings that could occur from reduced morbidity and mortality. So I think that's an excellent suggestion, and as we continue to improve the economics behind the work, we certainly have to take those things into account.
To this point, if I can just answer to this, can you hear me? I just was looking that up this morning, and I found that actually there was a reduction in cost in the UK for that for an increase in fiber consumption, and there is a paper, Cost Savings of Reduced Constipation Rates Attributed to Increased Dietary Fiber Intakes in Europe, and that cost saving was 127 million pounds in the United Kingdom. This seems to be work from Kellogg's Europe as well. So if we can save 200 million in Canada just with in diabetes, is that correct? Then maybe this is probably equivalent to another bit more than 200 million Canadian dollar, if this is true for Canada as well. Maybe the sewage problem is not such a big problem.
Well, the point is that a very, very careful accounting of all costs must be undertaken in order for the results to be reliable and to be useful in the public discourse.
Thank you. We have Furio Briganti for the University of Parma. We don't have Furio.
Yes, we do have. Okay, thank you. I enjoyed your presentation. I was just making a comment, maybe asking you a feedback on this comment about the. I'm a bit scared, a bit worried about the putting economy in healthcare in a strong way, because there are many, many variables that should be considered a part of the cost of care. Now, I would like to be facing a day the fact that by prolonging the life of a very elderly population would cost in terms of support for retirement funding for longer. So that is a very big cost that should be taken into account. And in my opinion, the whole idea to apply just econometric modeling in healthcare is a bit scary on that. And the second question is how it fits into an economic way of interpreting nutrition, the cost of the impact on the environment. No? So we all know that we should eat more fish, for example, but fish is a resource which is already on the edge to be completely exhausted. And again, we should make some consideration about the fat sources, no? And the productivity of the fat sources which are now present in the world, and there will be forecasting in a few years when there will be 9 billion people living in the earth. So it's something which is very, very complex. It goes well behind, in my opinion, from the data that you present here, which is only related to cost of care.
Very good. Just quick answer, please, or comment. Do you want to comment?
Yeah, thank you very much, sir. I like the way you think. You would make a fine economist. If we keep people alive longer, then we'll just have to pay for them. Please let them die. Now, I'm paraphrasing and just, I know that's not what you meant, but again, it does come to the same point as my colleague, which is that a more careful accounting of all of the costs is in order. But very good observations. Thank you.
I know we have much more questions, but we have, in order to save time, John is waving there. We have to kind of finish, and thanks a lot. Wonderful talk and great questions. Yeah.